Welcome to day two or three, depending on your counting. We have, of course, a wonderful resident program on Thursday. But here we are starting the Saturday program for the International Society for Coronary Artery Surgery. Welcome. This is a very exciting and interesting program, I feel, today. The topic of this next essentially 90 minutes is a conversation about international guidelines for coronary surgery. And we're going to start off by highlighting the global variation in revascularization strategies. That's the PCI versus CABG ratio, for instance, in different parts of the world. Dr. Bhakheian will talk about the need for a unified global voice on coronary artery disease management. And Connor Hines will give us a glimpse of one possible opportunity to collaborate the ISCAS Global Registry for Aortic Coronary Surgery. And then we're going to have a roundtable discussion with representatives from all over the world. Hiroshi Niinami representing Japan, Naresh Trehan and Sudhir Srivastava representing India. Our Chinese friends, Dr. Zhang, is he here? We will sub in from the United States, from the United Kingdom rather, Dr. Yadav and Dr. Folk and Milosevic from the European Union and EACTS. We have also Craig Smith representing the United States and William Fearon representing the United States. Craig, as you know, is past president of AATS. We've got Dr. Folk, past president of EACTS. And between Dr. Trehan and Dr. Srivastava, I think they control most of coronary surgery in the world's largest democracy. So we've got an authoritative group of people to have a conversation for the first time about the concept of international guidelines for coronary surgery and what might be first steps. But to launch this, we want to talk about the global variation in revascularization strategies. And Emma Hansen had a terrific presentation on this topic at the excellent EACTS meeting in Copenhagen a few weeks ago. And we've asked her to give us a replay this morning. Dr. Hansen.
So, John, sorry to interrupt, Dr. Hansen. I just want to, as one of the moderators, I just want to frame what we're going to do today in terms of why this is very important. Now, we have a number of experts, as John has said, from around the world, and it goes from Azerbaijan to the USA. So we cover kind of most things. But I would like to just, as I say, try and frame what we're trying to discuss today. Could I have, please, now, and by the way, I think there are 4 people who have brought slides today. And so that we keep the concept of discussion open, I'm going to limit everyone to 10 minutes. So whatever presenters we have, they have 10 minutes to show their slides, and then we're going to interrupt, because what we really want to do is have this as a general discussion with the audience. So what I'm going to do in the next 5 minutes is try and frame, why do we think this is important? Why is it time for an international guideline for coronary surgery? And as I've said, we've got experts from around the world. I'm looking at Dr. Falk, who was very strong. We worked together in the 2004 European guidelines. So he's been very strongly involved from a European perspective. So let's look at this. Sorry, my slides are not advancing. Right, here we are. I'm going to start with this, and I think it frames everything we should think about, everything we do, and what we should always think about in the future. And this is from Marcia Angel, a former editor of the New England Journal of Medicine. It's not a random journal, an editor of the New England Journal of Medicine. And she wrote in 2009, talking about drug companies and doctors, a story of corruption. And I referred partly to this yesterday in the Excel trial, the way clear clinical evidence was distorted to suggest that there was no benefit of CABG in patients with left main disease. But she wrote in 2009, conflicts of interest and biases exist in virtually every field of medicine, particularly those that rely heavily on drugs or devices. It is simply no longer possible to believe much of the clinical research that is published or to rely on the judgment of trusted physicians or authoritative medical guidelines. I take no pleasure in this conclusion, which I reached slowly and reluctantly over my 2 decades as an editor of the New England Journal of Medicine. So this is not a random journal. This is the New England Journal of Medicine. And why her prophetic words in 2009, why are they so important today? If we go back to 2018 and look at the ESC-EACTS guidelines for myocardial revascularization, they gave virtually a Class 1A indication to almost every aspect of coronary bypass grafting, and especially for patients with proximal LAD disease. And why is it important in our clinical practice? Well, if you look at left main with coronary artery, additional coronary artery disease, you see that 2/3 of patients have significant disease independent of the left main stenosis. And that accounts for about 2/3 of our clinical practice. Now, CABG is a Class 1A indication, PCI a Class 3 indication. And yet, if you look at what happened in the EXCEL trial, you can see the way good clinical evidence was distorted to try and deny the benefit of CABG. If you look at patients with 3-vessel disease with or without diabetes, you can see there is still a Class 1A indication for CABG. But what then happened in clinical practice? 2021, the ACC, the AHA, and SCAI gave their recommendations for what we should do with patients with severe coronary artery disease. And what did they do? They downgraded the recommendations for CABG in almost every clinical indication. And what was their evidence for downgrading CABG? It was non-existent. They based it on a trial called ischemia, which was not a trial of PCI versus CABG. It was a trial of either early or delayed intervention in patients with coronary artery disease. Now, thanks very largely to initially AATS under Dr. Joe Sabik, Dr. Faisal Bakin, they widely rejected these recommendations. They were not evidence-based. And if you heard my talk yesterday, they ignored a vast body of evidence showing the superiority of CABG over PCI. So these guidelines were formally rejected by almost every society of cardiac surgery worldwide. Sorry, there's some delay in this. My slides are not progressing. The point of these guidelines is they were a real danger to patients. So it meant that most doctors who were not experienced in coronary artery disease would say to patients there was no benefit of coronary artery bypass grafting. So the guidelines were not only misguided, they were actually dangerous for patients. If we now look at what did Europe do, Europe again got it right. And I have to say to Mr. Trump that despite all of his announcements, occasionally Europe does get it right. And we got it right in the 2024 guidelines. These were written by 28 experts from 13 countries, reviewed by over 40 experts. And what did they show? They showed that what the same as the 2018 guidelines had shown was that for most patients with significant coronary artery disease, the best treatment is coronary artery bypass grafting. Every patient with proximal LAD disease, independent of any other coronary artery disease, should be offered the benefit of a mammary artery. Whether they want the operation, median stenotomy, minimally invasive, doesn't matter. Should the patient be given that option? So in the UK, we have probably the best multidisciplinary teams in the world. So we will offer all patients with proximal LAD disease the potential benefits of a mammary artery. So if you look in contrast to the ACC/AHA guidelines, if you look at these guidelines from Europe, they were approved by every society of cardiothoracic surgery. So I go back to the prophetic words of Maria Angel, which was, be very careful when you're looking at what trusted physicians say, what clinical trials say. Excel was a perfect example. So be very careful what you think about and what you believe in. So on that point, I hope this helps frame what we're going to do today, which is discuss, is there a need for international guidelines? And if so, what would be the logistics and the practicalities of doing that? Thank you.
Thank you, David. Dr. Hansen is going to give us a global view of the variation in revascularization strategies. Dr. Hansen.
Thank you very much. Thank you for the honor of the invitation. And my name is Emma Hansson, and I'm a cardiothoracic surgeon from Gothenburg, Sweden. And I will give you this overview over the global variation in CABG versus PCI utilization over the world. As we are all well aware, and as it is represented here in this room, ischemic heart disease is a very global issue, as illustrated here by this graph of mortality from ischemic heart disease over the world. And when it comes to treatment choices, we have the very important treatment choice between the stent and the scalpel, which has very high implications for our patients. And to guide us in this decision, we have the clinical guidelines, which is what this session today is going to be addressing, which gives us clear-cut instructions as to which characteristics of the patient that should point us in which direction. And this discussion should be led by a competent heart team, hopefully free from concerns of individual financial gain or constraints from limited healthcare system. So, does this beautiful ideal mean that it is the same decisions made everywhere? Does the same patient with the same clinical presentation get the same treatment decision regardless of where they are in the world? Well, definitely not. The PCI and CABG rates vary greatly over the world, and I will try to give you sort of a rhapsody of different ratios as an illustration of this. Let's start with Canada, where different regions report different numbers, but it varies between 3 to 8 to 1 PCI to CABG. The US, 4 to 5 to 1. Europe, UK, 8 to 10 to 1. Sweden, we arrive at 10 to 1. South Korea reports 19 to 1 PCI to CABG. Japan, 25 to 1. Brazil, over 20 to 1. Australia, 3.5 to 1. Germany, 10 to 1. China, I have oral information from a surgeon I met at the ACDS, but that it is about 20 to 1. And also, many of these numbers are quite hard to come by. Not every system reports their numbers so that they are readily available for the patients, for financiers, for caregivers. But I will try to delve into some of the details from the healthcare systems that provide a bit more of the detailed information. And I want to start in the UK, where publicly available numbers show an evolution over the last 10 years, where CABG numbers have declined, giving us a ratio from 4 to 1 to 8 to 1 in the recent 10-year period. And the system that I am even more familiar with is the Swedish system, where we have a lot of healthcare registries with rather high resolution. And these are our national numbers for PCI versus CABG in all patients, all revascularizations, excluding STEMI. And the individual columns represent different healthcare regions in our rather small and very homogeneous and it's a healthcare system that prides itself of being egalitarian and including everybody. And still we have this rather alarming discrepancy between different regions. From 20% or 25% of revascularizations by CABG to about 5% in the least CABG-friendly regions. And what is worth to note is that in the Swedish healthcare system, patients are not able to choose their cardiac surgery or their cardiac care center. You are simply awarded one depending on where in the country you live. So this does not reflect individual patient choices. It really reflects different treatment cultures in different centers. And this is, as I said, the entire cohort. There could be a lot of factors, but when we look at the subgroup of patients with diabetes and multivessel disease, which, as we have seen in the excellent presentation by Dr. Taggart, these are patients that should really be, in most cases, referred to CABG surgery. We have a very large discrepancy where the most cardiac surgery friendly regions arrive at 1:1 to PCI CABG, and the least the regions where we utilize CABG the least are at a 7.5 to 8 ratio PCI to CABG. The same pattern is shown also in the UK, with also a large variation from 15:1 in some centers, down to 3:1 in some other centers, and this is also the global all comers. There was also an interesting publication from Canada a couple of years ago where they included over 44,000 patients who had their non-emergent diagnostic coronary angiograms showing a severe multivessel coronary artery disease, and then they had a subsequent coronary revascularization procedure performed within 90 days. And they divided patients from the low PCI to CABG ratios, which is sort of the surgery-friendly regions, to the medium and high. And what I think was very interesting and elegant in this study was that they also compared this to the actual long-term MACE outcome for these patients, showing that patients who had their coronary angiogram done in a center where you were prone to send the patient to PCI actually had a higher risk of MACE, a lower survival expectancy afterwards. And also, as noted in the last couple of lines here, patients who had their coronary angiogram done at a center where there were no CABG capabilities, they also had they had higher MACE and lower expected survival afterwards. So what drives this variation? It could, of course, be a question of access to cardiac surgery or cath labs, and that is something that is seen also in various regions, large regions over the world. Europe and North America have a higher access to cardiac care centers compared to the developing world. We also have the issues of financial or reimbursement concerns, which is a reality that we have to live within. But we also have the very important aspect of culture and training. And this, of course, is something that we have to discuss with our interventional cardiologist friends and colleagues, but it is also something that we have to discuss within the cardiac surgery culture to arrive at the right conclusions, which patient would benefit from which treatment. And something that I would also like to stress is I think there is an importance in reporting the results, because if we have readily available results, which patients go to which treatment and what are the outcomes afterwards, there could sort of be an accountability to guidelines adherence, which I think would be a very important concept. And that is something that has been discussed in Sweden, since we have very available publicly reported figures of outcomes and also treatment choices. It is available for patient advocacy organizations and for the healthcare politicians in a way that I think is beneficial for the discussion. So to conclude, we do have a large regional variation, both on a global scale, but also within countries and healthcare systems. And this regional variation, as shown in the Canadian study, undermines patient outcomes. And that is why we need the guidelines as a roadmap for fairness and science-based care, because geography shouldn't decide therapy, evidence should. Thank you.
I think you can all see why we asked Dr. Hansen to join us here today. Please come and sit next to me, Emma, if you would, and we'll welcome to the podium Dr. Faisal Bakin, one of our co-chairs of the program committee this 11th International Coronary Congress. Faisal's been actively involved in discussions about the appropriateness of criteria used for guidelines, and we look forward to his comments about the urgent need for a unified global voice on coronary disease.
Thank you very much, John, and thank you, David, and thank the audience for being here at this early hour on a weekend. But this is a worthwhile meeting. This is the premier coronary meeting of our time, and congratulations again for having the most number of registrants ever. And obviously this meeting is growing, and a testament to the importance of this meeting is the international attendance, not just in the panel here, but in the attendees. And this is a coronary meeting. It's not just a CABG meeting. So welcome the cardiologists that join us. Dr. Fearon, thanks for being with us. I'll try to be as nice as I can. You know, at the personal level, we get along really well. So don't take anything personal. So that is not my slide set. I wish I was as good looking as Milan, but my name is Bakaean, B-A-K-A-E-E-N. Yeah, that's more like it. Let's see if I can advance it. All right, well, we all get along with our cardiologists. I mean, at the clinic, we've done more CABGs this year than any other time for the last quarter of a century. We did 2,200 cases of isolated and combined CABGs. Roughly half were isolated. And everything was dandy at a professional association level until this document came out. And David Taggart talked about it. And the reason why it was controversial is because it was the document that downgraded CABG for the first time. And it was very destructive, very, very destructive. But Taggart had nothing to do with it. You're innocent.
Thank you.
But this downgrade of CABG, we were told, and I quote the guidelines group, this is based on new evidence. You guys are living in the past. We said, well, not too fast. We know the evidence. The new evidence that you furnished for us is the ischemia trial, and like David so eloquently explained, it's a strategy trial. Not a single patient was randomized to CABG. Not a single patient was randomized to PCI. So it's not really a level 1, level A evidence, and it's something that we can't hang our hat on. It's really non-admissible in terms of evidence. And CABG accounted for the minority of procedures in the invasive arm. There was some crossovers over a very short period of time of 3.2 years. When we offer CABG, we talk about 30 years plus. We don't talk about 3.2 years. And then there were some anomalies. The complete revascularization rate in ischemia was 35.7%. This has never been that low. In Syntax, it was in the mid-60s. Any other randomized trial, it was in the 60s and 70s. So why half the completeness of revascularization rate for the first time ever? That raises a red flag. Are the data robust? Can we trust the data? Even if we were to trust the data, only 36% of patients had a proximal LAD lesion of greater or equal to 50%. Notice 50%. If we go up to 70%, which is the definition of a severe lesion, that number will go down. When was the last time any of you in this room operated on a patient that does not have a significant proximal LAD lesion? I haven't.
No.
So really, if a picture speaks 1,000 words, that describes it. So this new evidence was jammed in to justify perhaps a political downgrade rather than a scientific-based downgrade. And as David pointed out, there was a global outcry, not just from surgical associations. Many of them were actually cardiovascular associations, so it included cardiologists and medical specialties. Fortunately, our European colleagues looked at the data, looked at the evidence, and they decided to upgrade CABG. And they included lots of thoughtful cardiologists, surgeons, and input from multiple countries. And therefore, the surgical societies felt that this is something that aligns with the evidence and worthy of support. But did the Europeans look at different data or different evidence? No. No, they looked at the same existing evidence when they made those new recommendations. But the new thing was the perspective of how you look at CABG, how you look at PCI, and how you look at medical therapy. And Torsten Donst, who is with us today, wrote this magnificent collaborative editorial in JACC, a cardiology journal, explaining the difference between PCI and CABG. What PCI achieves is it bypasses the lesion of today, but it also provides protection for lesions of tomorrow. And if you look at adverse cardiac events, spontaneous MIs, 2/3 of them occur in lesions that are 50% or less, as demonstrated here. And again, I like to show pictures and images to prove the point. This is a patient who's 91 years old, who 30 years ago presented with stable coronary artery disease and normal EF. And you tell me, well, how do you know that patient? How do you know the details? I usually don't say that, but I'm going to say it today. This is my father. And my father's angiogram is demonstrated here. He's got a totally occluded RCA, totally occluded left main, yet he's alive. He's a dentist. He goes to dental clinic every day. He's got macular degeneration, but he still extracts teeth by tactile sensation. No, honestly, yeah. He's not living because of optimal medical therapy. He's not living because of stents. The reason my dad is still alive is because of a single patent graft. All his veins are down. He had CABG ×4, by the way. And this mammary lights up the entire heart through collaterals. This is unique. This is undeniable. Now, the problem that we have right now is the American guidelines say one thing, the European guidelines say another thing. Now, the patients are confused. I mean, it's unfair to our patients, unfair to the medical community that treat those patients, because it's kind of schizophrenic, those recommendations. And this transatlantic divide that I outlined in this JAMA Surgery editorial really speaks to that, but it also offers an olive branch. Hey, let's come back together, look at what we have. If we need to downgrade CABG, it has to be an expert opinion, not a level A evidence, because there is no level A evidence to downgrade CABG. And this is particularly important because when we were at EACTS, Dr. Falk was the president when we celebrated the annual meeting at Copenhagen, and people from South America and other countries mentioned that their payers, their insurance companies or their governments simply don't cover therapies that are 2A or 2B, specifically 2B. So we could deprive certain patients from having life-saving therapy, and that's why it's dangerous, as Dr. Taggart so clearly demonstrated in his talk. So what is next? I think in the interest of time, we all know we need to get together, we need to shed the differences of the past, and we need to work collaboratively, thoughtfully, and we already did that amongst the surgical societies. EACTS, STS, AATS, the European Thoracic Surgery Association got together and said, listen, we want to get together, agree on how to do guidelines, agree how to examine evidence, and we all agreed that we have to do it collaboratively. We have to do it collaboratively. We also felt that the surgeons need to be more involved, need to be more educated, need to know the data and the process very well. And when we collaborate, we have to collaborate on an equal basis. We can't have a token surgeon or two that don't know the data, that are yes surgeons. Those are thoughtful surgeons that know the data. We need to address conflicts of interest. You can read that document and see the details that me, Milan, and others, and Milan is here. Thanks for being here. So I would conclude by saying it's time for the cardiovascular community to raise the bar and harmonize future guidelines. Now, it doesn't mean that we're going to have a global guidelines. We could still have European, American, South American, Asian, you name it. It's fine. Competition is nice. It stimulates us. But we have to have high standards. We must not repeat the mistakes of the past. And the surgeons have to be involved from the level of the trials, actually, even before the guidelines. We need to know the literature better than everybody else. We need to demand high standards and speak out if there's any issues. We need to arrive to the best recommendations for the benefit of our specialty and our patients. Thank you very much.
Thank you, Faisal. We're going to have a very brief presentation by Dr. Connor Hines, who is presently my advanced coronary fellow at Emory University and who has put together, through the cumbersome IRB process and other data sharing agreements, etc., the backbone for a small tiptoe into a global registry. This will be the ISCAS Global Registry for all arterial no aortic touch off-pump bypass. and Connor's going to briefly present this. And we do that in the spirit of an example of what might be possible. I think this could be a little test case for much bigger and broader collaboration internationally. Dr. Hines.
Thank you, Dr. Puskas. Good morning. I'm very pleased to introduce to you all a new international registry, as was just mentioned, for anaortic off-pump CABG. I have no disclosures to report. The purpose or the idea behind the registry is to collect data for anaortic and clampless proximal off-pump cases performed in particular by routine surgeons. This will be affiliated with the ISCAS and will be based at Emory University School of Medicine. The general premise is that we will be providing an annual data analysis and reporting of the data that we collect. So as I mentioned, really fundamentally, we want surgeons who are routinely performing these cases, who have a certain experience level, so that we can benchmark early and late clinical outcomes for the surgeons who are skilled in these complex techniques, and to share and understand innovations and techniques that may be differing among different surgeons. The basic data use agreement would be that all data will be de-identified as it transfers across international borders. It will be housed in a secure, encrypted online platform. All participants retain ownership of their data, and there will be shared authorship of any publications of the findings. The minimum requirement is surgeons who have performed 50 cases or more, institutions that have performed 100 cases or more of anaortic and clampless proximal cases. And of course, we want surgeons to submit all of their cases consecutively without cherry picking out or censoring any cases. Simply 53 data fields, some preoperative, angiographic, intraoperative data points, including the conduits, the targets they're going to, and the TTFM measurements, and then several key postoperative outcomes and the annual survival status, if that can be attained in your country. So the next steps, if you're interested, you want to participate, is to contact me. The QR code has my email address. It's also there, my phone number, and the data collection form is attached as a PDF, so you can peruse those data points and the things that we're going to be collecting. We will require each participant to submit an IRB protocol at their home institution, and then from there we can get started. So I'm looking forward to hearing from those of you out there who'd like to participate. Thanks very much.
Thank you, Connor. Dr. Emila Milosevic is going to give us a brief European perspective on behalf of EACTS, and he's sitting here next to Dr. Falk. So, Milan, please.
Thank you so much, and thank you for the privilege of the floor. So I will shorten my presentation as much as possible because Dr. Taggart and Bakin already covered many of these topics. So these are my disclosures. So learning objectives, just want to stress out why these guidelines are so important. And we understood that we have a need for the unified global voice and how we can get to that point. So ESC and EACTS has a long-standing collaboration on myocardial revascularization guidelines starting from 2010, then the 2 updates. But then when results of the EXCEL trials are published, the EACTS decided to withdraw the support from the left main recommendation. And while we're working together with the ESC to try to update this recommendation and waiting for the TIMI study group for the independent analysis, and our aim was to publish this paper, the ESC decided to change the scope of their guidelines and to merge the myocardial revascularization guideline together with the chronic coronary syndrome guideline into one guideline. So our left main paper became obsolete once it was published. So why these European guidelines are so important? So as I said, we've withdrawn the support. Year before that, STS and AATS have opted not to endorse the American guidelines, and we knew that there is not going to be new myocardial revascularization guidelines. So we know that this is very important and we need to find a way to succeed. And this is the timeline of this guideline project. It's a typical ESC timeline that takes more than 2 years. And this guideline was published in August 2024 and officially endorsed, and this is important, especially when we're discussing the ratio of PCI to CABG. I need to emphasize it's officially endorsed by 39 national cardiological societies in Europe and become immediately their national guidelines. So we decided to move away from ischemia as the most important trial for determining whether the patient needs the revascularization or not. We know many issues with ischemia. I just want to point out the issue with the custom-made definition of periprocedural myocardial infarction, which from my perspective, fortunately, I have no access to the RAF data, has influenced the primary outcome of the study. If the authors opt to use the universal definition of myocardial infarction, which is accepted in Europe and USA, I can bet that the primary outcome of the ischemia trial will be different. So we move away. We look at the totality of the evidence. There is about 25 RCTs with 20,000 patients over there, and this evidence, the pool together, showed that early revascularization is associated with reduced mortality and reduced spontaneous myocardial infarction. So we had no any doubts that revascularization should be recommended in patients with 3-vessel disease, left main disease, and 1 and 2 vessel disease with the proximal LAD involvement. Then we decided to distinguish the indication of revascularization based on presence of the heart failure with reduced left ventricular ejection fraction. You all no need to repeat the results of the STITCH trial. You're all familiar with them. But what happened in the meantime, the REVIVE, big trial, was to publish, to compare the PCI and optimal medical therapy in these patients, and was completely negative in terms of the heart clinical outcomes, in terms of the quality of life, in terms of the echocardiographic parameters. So the European guidelines are very clear. Patient has a heart failure, it's recommended for CABG, and the PCI might be considered only high surgical risk or non-operable patients. So for those with preserved left ventricular ejection fraction, so we have divided this recommendation and from 5 different aspects. What is I think the crucial point of this guideline that is often overlooked is that how we should make the decision to revascularize our patients. And in this European guideline, the heart team has a central role. What we have for the first time, and this is with the purpose to avoid having the ad hoc PCI at such a high level like Emma showed this morning, is that if patients if the CABG and PCI are equally recommended in a particular patient, this patient must go to the heart team. So this is the big difference and the big change than any other previous guideline. And of course, the many centers, they have a cath labs without surgery on site, then it's a must that they establish the formal collaboration with the surgical site and then together decide what is the optimal treatment in these patients. So left main trials, you're all familiar with that. What is something that is not published in the Lancet paper, but was reproduced by our request from the TIMI study group, is that if we are looking the composite endpoint of death, stroke, and MI according to universal definition of myocardial infarction, then we see about 4% absolute risk difference in favor of CABG, which is very statistically significant. So for left main, we had again the endless discussions over the period of 2 years, but we ended up that the CABG is the preferred treatment modality and PCI is alternative. What is very important in this guideline is that if the patient has the left main and multivessel disease, and this is about 80% of the patients, then surgery is recommended, and PCI might be considered again in a very selected population of high surgical risk patients. So for the multivessel disease, you all know this paper from the Lancet, and also you're probably familiar with the results of the FAME3 trial, which actually failed to show the PCI is non-inferior to CABG in 1 year, but there is a lot of spin that you can see at the 3 and the 5 year publication when authors opt to not use the repeat revascularization anymore as a part of the primary composite outcome now, and they present the result that there is no difference between PCI and CABG. But this is the reason why we have a guidelines, and this is something that we are discussing within the task force. So complete revascularization is very important, and Faisal mentioned in the schema was just 35%, and we know irrespective whether we are using the anatomical or the functional definition of completeness of revascularization, the outcome in those who are completely revascularized are much better than those who are not. So for the multivessel disease patient, if diabetes is present, then CABG is recommended, and again, PCI should be considered in very high surgical risk patients. When we are talking about 3-vessel disease without diabetes, then the completeness of revascularization plays a major role in determining whether the patient should undergo PCI or CABG. The single and double vessel disease, unfortunately, we have not too many data on this topic. We have only one small trial that was conducted in Leipzig about 20 years ago, but we have some registry data. There is no difference between PCI and the CABG up to 5 years of follow-up in terms of hard clinical outcomes, but there is much more repeat revascularization with a PCI in comparison with CABG. So the recommendation for single and double vessel disease, if there is a proximal LAD involvement, then decisions should be made within the heart team, because both PCI and CABG have a class 1 recommendation, and then if there is no involvement of the proximal LAD, then the PCI is generally recommended over CABG. For a deeper dive, I can recommend this paper, and I just want to stress out, maybe you can see in the left top corner. So this is something that we have conducted in my center in Belgrade last year, because there is always a lot of discussion on how we can have that number of the heart teams. So the last year we have a 13,000 heart team decision makings. So we have a daily meeting from 7:30 till 9, sometimes even longer. And as you can see, almost 4,000 patients were indicated for CABG, only 1,600 PCI, and the rest of the patients were recommended continuation of the optimal medical therapy or some additional examination. So having the profound heart team discussion at the daily level is something we should all stream for. You all know that these guidelines are now officially endorsed by many other surgical organizations. I want to just use this opportunity also to stress out that yesterday Dr. Verma talked a lot about the compliance with guideline-directed medical therapy, and this paper was actually the product of a fantastic idea, Professor Taggart, so which shows that clearly that the CABG patients are largely undertreated in this regard. But what Dr. Verma didn't mention is that the ESCTS, we now have a second edition of the guidelines for the perioperative medication, and I would like to refer you to them, and you can get much more insights. I think these are very important guidelines. Of course, we need to have a unified voice. Why this matter? It's matter because divergent recommendation, mixed messages, and nobody believes in guidelines. And then we have a problem with implementation, and we have a huge variation in PCI to CABG ratio, as we have witnessed this morning. What are the root causes of divergences? We have a different methodologies for guideline development, and frankly, we also need to speak that we have different incentives and different perspectives. So we all follow the general principles of the National Institute of Medicine. Also in Europe, they have provided a set of criteria for trustworthy guidelines, but these criteria are like a constitution. They are very general. So you need to apply the certain laws in order to have the final methodology. And that's the reason why all the methodology that we are using in the cardiovascular fields are different. So we have no universal accepted standards among major guideline development, and this is probably one of the reasons why we have divergent recommendations too. So what is the current status? We had a lot of talks, and we have a couple of sessions also together with AHA, ACC, ESC, trying to bring this different point of view together. Unfortunately, what happened, we have all updated our methodology, and I think today we are even further apart than before updates. So ACCHA has updated their methodology and just published 1 month ago. ESC did the same, and we, as all the surgical organization, actually we have produced our joint methodology, which is different than these two methodologies. So my key takeaways: the former myocardial revascularization guidelines are now part of the CCS guideline. So these are the firm recommendation. As you have seen in my presentation, they put the central role of the heart team over there. They recommend the CABG in patients with more complex disease like a high syntax score, diabetes, heart failure, left main, and multivessel disease, and PCI is the preferred in patients with 1 or 2 vessel disease without proximal LAD involvement. Despite the progress, guideline methodologies and recommendation across major organizations remain heterogeneous, and further CCS projects must therefore focus on a deeper collaboration between the surgical and cardiological societies. We are trying to do that in Europe and to extend this to the transatlantic level, which is at this point very challenging, but we are trying to find a way forward, but we are far away from being at that point. With that, I would like to thank you for your attention.
Thank you, Milan, very much. Volkmar, will you come to the podium? Come and join me here, if you would, please.
Okay, so really now I'm looking forward to this next 20 minutes or 30 minutes of conversation with this group of experts. And I want to hear, we all want to hear from those who haven't had a chance at the podium yet. We have representatives from the UK, from the United States, in cardiology and surgery, from the European Union and from India. What is the next step that should be taken? Dr. Smith, past president of AETS and a global leader in surgery. Well, what is doable?
Is this on?
Can we activate the mics, please? Done.
Done? Okay.
Yeah.
Is it working?
Yes.
Okay. Well, there are a number of things I'd love to react to in what's been presented. If you're to keep it to a next step, I think you're on the right track conceptually by maybe taking a side step away from all the endless controversy over one guideline versus another, and making sure we continue to carefully track our outcomes, because at the end of the day, however the pendulum is swinging, we can step in and demonstrate our outcomes with fidelity. That will help us. But I can't resist commenting that in the proposal from your institution, your definition of routine, I gather, is surgeons for whom aortic off-pump surgery is routine?
Yes, so this is a tiny segment
Yeah, I
of the
was going to
coronary
say,
world.
that's-
It's 1% or something.
Yes, why
Yeah.
not make them left-handed females?
Right, yeah, sure. That's a tiny example, yeah.
And that is far from routine.
Yes,
And then you step into the whole issue that was alluded to in the first talk about access disparities based on regional distribution of expertise and resources and a whole host of other things. So setting all that aside, though, I think the first step is to make sure we continue to carefully track our results, which I would be the first to say, personally, I did a poor job of, but I could do that because I knew New York State was tracking it pretty well, so.
so following outcomes and then sharing them across international borders, or should we be building a global registry of all coronary surgery? Is that feasible? Is that advisable? Is that something that would inform guidelines?
Well, feasible and possible, that's the trick, but conceptually, yes, I think that
Yes.
would be a great thing to do.
Dr. Fearon, the only cardiologist at this podium right now is you. And we're grateful that you're here. You're the first author of the FAME trial and many other important landmark trials in coronary care. Give us your perspective on a doable step forward. We don't need to sort of rehash how did we get here. I would like to have your sage advice about how to get out of here.
Yeah, thank you. Thanks for having me. It's a pleasure to be here. I wanted to just, make one specific comment about the last talk. I'll talk about it more this afternoon, but regarding the FAME-3 trial, there has been this concern that the endpoint was changed along the way. And I'll cite our original design paper that we published in 2015. When we designed FAME-3, we chose a 1-year death, stroke, MI, or repeat revascularization as the primary endpoint because we wanted to recapitulate syntax with the new stents and with FFR guidance and keep everything else the same. But we already acknowledged in that paper and at that time that repeat revasc has a number of limitations as an endpoint, and we pre-specified looking at just hard endpoints that we think are clinically relevant, the steering committee, including cardiac surgeons, of death, MI, and stroke. Because there's other endpoints that tend to get ignored, like rehospitalization or atrial fibrillation or other things that often happen more frequently after surgery and not after PCI, whereas repeat revasc clearly happens more frequently after PCI. But over the years, as an endpoint, it has diminished in clinical significance. I think many people agree. So anyway, I just wanted to clarify that that wasn't an arbitrary decision. Oh, let's just get rid of repeat revasc because it makes our data look bad. We, pre-specified that and wanted to look at that. So anyway, what can we do now?
I think that's an important point. And in fact, I went back and read the original paper, and what Dr. Ferron says is completely correct. It's in black and white in the original paper. I've read it.
Thanks. What we can do now, I think as proceduralists, speaking as an interventional cardiologist and with my cardiac surgery colleagues, I've been just as frustrated by the downgrading of the guidelines. And I feel like there's a number of different issues. One of them is this parsing out of benefit, like we should do this to improve mortality, or we should do this to improve symptoms. Patients don't care about that. They want to feel better. They want to live longer. They want everything. They don't want to do one thing just because it's going to improve their mortality. And that's been frustrating because I think that was one of the things that drove why CABG was downgraded. Because yes, if you look at current data and with improvements in medical therapy, maybe the improvement in survival is a little bit less than it had been. I'm not sure. We need to do, and that's another point, is I think as proceduralists, we need to run these studies. I think some of the studies that are being done are including lower risk patients, and then they're being applied to higher risk subsets, which skews our interpretation. So I think there's so many things that we do for our patients to help them feel better and that have no effect on mortality, hip replacements, knee replacements, and they have class 1 indications. Why shouldn't revascularization have a class 1 indication? Just, if we don't improve death, that's not always the end all and be all. So I think that's something easy that I think we could change, is how when we list the guidelines, that it's not just for mortality alone. It's for mortality, MI reduction, symptom improvement, and I think everyone would agree that revascularization helps for that.
Back in 2011, the American guidelines, I was part of the committee that wrote them, we broke out. These are the recommendations to improve survival, and these are the recommendations to improve symptoms. And they were not the same, right? Because they were two different goals, and I thought that actually made sense. Dr. Trehan and Dr. Srivastava, you are major leaders in cardiovascular care in the nation of India, population 1.5 billion, now doing more coronary surgery and probably more PCI than any other nation on earth. Tell us about the data that you're acquiring. We saw Emma Hansen try to estimate PCI versus CABG ratios in India. Do we have granulation about that? Granular data about that, and how variable are those revascularization strategies in different parts of your very large country?
So, John, if I may show some slides.
Sure.
Just to be able to tell you what the challenges are. So, if you want, I'd come and run my slides from there.
Sure. Okay. And just so everyone's aware, it's 9 o'clock. At 9:20, we're going to vacate this stage. And so I want to have, because we're going to have our keynote speaker come to the stage. Here we go.
I'll be quick. Okay, so, I just want to walk you through some of our experience. Can you? Okay. It's a little different on the front screen and my screen. So the total number of surgeries, there are 420 centers in India now. The total cardiac surgeries done is 150,000, total surgery being 250. So the coronaries are about half. And total valve surgeries, the main point is that the off-pump surgery has taken off hugely in India, where 75 to 80% is being done off-pump. Several reasons for that, but most importantly, we started way back in 1995 when we did the last operation. And since then, we actually have, I'll skip through some of the slides just to get to the meat of it, that we presented at the ISMICS meeting in 2005, 50,000 cases of CABGs that we had done at Escorts Heart Institute, and out of them, 14,000 were off-pump. But if you look at our experience now, because I'm at another institution, I'll just walk you through for CABG done on patients off-pump, the mortality is actually below 1% consistently over the last 3 years. We don't have that data accumulated yet because the mining has been a little deficient. But the safety of off-pump surgery has been established quite well in our experience over 60,000 patients now. What the problem is, when we talk about guidelines, international guidelines, we have different disease form across the world. This is not an unusual picture that we see in India on a daily basis. This is what we are operating on. And so if you want to, I mean, this may be one of the worst ones, but this is the kind of diffuse disease that we see in India all the time. And I did have the opportunity of being in the United States for 20 years, so we've been operating on the Caucasian or European population. This totally different kettle of fish. So how do you establish guidelines which are universal? So I think we go back to the point that we need to redefine what regionally we should be doing as data collection and also the fact that we do practice heart team every morning. We do have natural selection. Today we have, and also it's a changing landscape. Every technology changes every 6 months. Now, cardiologists have honed their skills. Technology has has moved much greater distance than with cardiac surgery. Cardiac surgery is also moved. Now, proportionally, our minimal invasive surgery has gone up almost 50%. So we are talking about morbidity, mortality, different disease forms. We have the highest burden of diabetes also, so this is why you see these kind of vessels. So I think that regionally we should, one of the speakers before did say that we should start regional registries and try to then come up with guidelines region by region or maybe universal. But the fact is, it was well established that left main was the domain of surgeons. It has changed significantly. Not to say that cardiologists who have been doing it, at least in my experience, in our institution, or we see a lot of it, where the bifurcation lesions are stented and you get the worst form of disease. The LAD is open, but the circumflex has, through the stent, has such a tight lesion that the patient is symptomatic, is hugely ischemic, and then what do you do with them for a single vessel disease? So I think that these challenges keep changing to us, and I would suggest that we actually, as a collective group, to internationalize our registry and analyze it more regionally, depending on what kind of disease that exists in that country. Thank you.
Thank you, Naresh. So what we're hearing is a global theme, beginning with Dr. Smith, but now Dr. Trehan, to perhaps simplify and globalize data registries so that we can really understand what we're doing and for which patients we're doing it. Does that resonate with you, Dr. Falk?
In principle, it does, but I see all the difficulties. We know that registries only work if they're compulsory. I mean, I think registries that are not totally inclusive of every single patient are useless. The information will not be valid. Registries have to be audited, which is very difficult to do and achieve. If they're not audited, they're useless. And also, they're not typically accepted by guideline committees. So we have this discussion in the Valve TAVR-SAVR debate, whether or not registry data are useful or not. And by definition, and the methodology papers all say the same in this one, RCTs lead the discussion. So whatever you bring in terms of registries will be disregarded, or at least just in the best case mentioned. And my personal experience with registries in our country is that it is very difficult to get the full documentation, that if there's no incentive to do it, for example, coupled to reimbursement or something really strong, people are just too lazy to do it. Documentation is already something that we hate, as surgeons in particular. 40% of an average German physician works, 40% of his workload is documentation. So whatever you do on top of this is not going to be well accepted, let alone the problem of cross-country registries with different data protection laws. So while, yes, would be nice to have, I think it's totally unrealistic to get an international coronary database together on top of what we have, like STS database, which is pretty much the best registry that we have. And in Europe, we're trying to do that with EACTS. So we set up a new database project and try to hook up all the European countries. And some countries don't have a national database, so they will submit their data to this one. And some centers will send their data. But it's not easy to get everyone aligned to send data. So then in the end, yes, what are the outcomes of these registries? And as long as guidelines would not recognize them, we won't change medicine through registries, unfortunately.
Well, I appreciate those comments. I'll point out that the STS took a long time to become widely recognized and accepted. As Dr. Smith knows, in some states that had their own state registries, centers were reluctant to sign on for another documentation task and expense. But now, finally, the vast majority, essentially all, of cardiac surgical centers in the country submit data to the STS, in part because CMS has a financial incentive, a carrot and a stick.
That's the point. There's an incentive to do it, and
Yeah.
it's very strong.
It is strong. With us also is Rajmi Yadav from the United Kingdom. Tell us about the database in the UK. Do you trust it? Is it real? Is there any hope that it could become a part of a global registry?
Thank you very much. So I think definitely the data is real and it is mandatory. And there is a lot of benchmarking of the data and checking of the data. So I would say that the NICOR data, which is available publicly, is a very, very strong database. It can be stratified by hospital to look at number of cases or the proportion of on versus off pump. So I would say UK data is very strong and it was mandated, as you know, as a result of poor outcomes some decades ago in pediatric cardiac surgery. So that definitely is a step forward. In terms of how we can address the problem of disparate guidelines between different regions, I think that ISCAS, as a collection of coronary experts from the world, holds a very important role and could take a leaf out of the book of societies such as ISMEX by publishing consensus documents. So what has happened in the UK, for example, is, of course, we follow the guidelines, but we also have the NICE guidance, which looks at cost effectiveness. So there are multiple layers, if you like, of guidelines which protect the operating surgeon. And in the US, if the guidelines have downgraded CABG to 2B, then our society could produce an international consensus document, which then provides an extra layer of protection for the operating surgeon, just as surgical societies dismissing or rejecting the ACC guidance is done. So those are my thoughts on how we could address this problem. I think there is a very strong reason for international guidelines, and different countries would benefit in different ways. And when I think about how UK would benefit from international guidelines, it is because we are a system which is free at the point of delivery to every patient. Our focus is giving the maximum benefit to maximum number of patients. So we struggle with innovation. Watching Gianluca do the procedure yesterday reminded me that it will be a long time before UK centres will reach that level to be able to offer robotic TCAP to patients. My centre does the biggest number of endoscopic limiter LADs, but the robot's a long way away. So having international guidelines will help countries like ours to aspire to what is an international guideline. So it brings us to that level, and it also protects countries like the US, where there might be a little bit more conflict of interest in terms of the making of the guidelines. So those are my thoughts about the guidelines and data from the UK.
Thank you for your thoughts and for being here, Dr. Yadav. Dr. Fearon, the conversation has been about surgical registries for coronary bypass surgery, but it seems to me that if we're going to have a real heart team patient rather than proceduralist focused culture around cardiovascular care, that we ought to have a combined database. I mean, certainly most centers in America have active cath labs and active surgical programs, but few of us actually have merged databases. The ACC NCDR is a robust database, and the STS database is robust. Do you ever imagine that we could get them together? And could that be a global model? Because at the end of the day, the ultimate would be to have every cath lab and every surgical suite linked in one data set, one database, nationally and globally.
Yeah, I mean, it's an interesting thought, and I think the practicalities are challenging because we also have to acknowledge that there's a number of patients that aren't getting surgery or PCI that probably should be included in that database as well.
Absolutely.
And how do you capture those? I mean, I think the old saying that registries tell us what we are doing and randomized trials tell us what we should be doing is very applicable here. And I think the registry information is important, but I go back to what Dr. Paquin said as far as getting as proceduralists, cardiac surgeons, interventionalists, we need to take control and we need to run good randomized trials and enroll the right patients and generate the data that demonstrates the benefits that I think all acknowledge are there, but haven't borne out because the studies, I don't think, are designed in the appropriate fashion and aren't including the right patients.
Thank you, guys. May I open up? Oh, got one. Thank you. So as you know, we're very privileged because of the efforts of Dr. Puskas to have Dr. Oz, who's going to come and speak to us in 5 minutes, so we've got to get out. But I do want to make one general point that's grossly underestimated in what we do as cardiovascular physicians. And it's the elephant in the room. If I ask you people in the audience, how many patients who undergo coronary revascularization, whether by PCI or CABG, how many are discussed by a multidisciplinary team? The answer worldwide is a tiny proportion. The decision is usually made by an interventional cardiologist who may or may not deem, and we're delighted to have Dr. Fearon here, but let's look at reality. What happens with the one exception in the world is the UK and Scandinavia, where we discuss if you need to intervene in a patient who's not a STEMI, it has to be agreed by a multidisciplinary team. And if you do that, you change the perspective enormously. Now, one day all of us will be patients, but I know in most of the world, we saw it in the PCI to CABG ratios, varying from 3 to 1 in some countries to 30 to 1 in another. And as Dr. Hansen showed us, even in Sweden, look at their ratio of PCI to CABG varying from 3 to 1 to 8 to 1. How can that be happening if you're using the same evidence basis? So what it's telling you is what's happening to patients is dependent on the whims and conflict of interest of the doctors rather than what's in the best interest of patients. So any patient who does not get discussed by a multidisciplinary team, and I don't mean doctors who say, well, we have multidisciplinary teams where the cardiologists bring what patients they want to discuss. Every patient has to be discussed. And one of the great things we can be proud of, as Dr. Yadav said, in the UK, that's what we do. So if you're in the UK and you have coronary artery disease that needs intervention, there's a very high chance you're going to be given the right option to treatment. And remember this, it's not all we do as doctors is recommend to a patient what we think is their best treatment. The patient never has to accept it. But I can tell you in the UK, if you explain to a patient why you're recommending CABG or PCI, and you explain the rationale for that decision, 98% will accept it. So it was just my little summing up. So I think the need for international coronary guidelines is absolutely overwhelming. I think Dr. Faisal Bakin and Dr. Joe Sapik have done a great job in alerting us to the dangers of guidelines. But the major problem we face is the elephant in the room, that the perverse conflicts of interests of doctors far outweigh what is actually best for a patient. And that's why I started my talk with that editorial comment from Dr. Marcia Angel, the former editor of the New England Journal of Medicine. You can't trust doctors, you can't trust trials, look at Excel, and you can't trust guidelines. Thank you everyone for being here this morning. Thank you.